Hey guys, how's it going? For those of you who don't know me, my name's Mike Loria. I was a pararescueman in the Air Force. I did combat search and rescue and special operations medicine, and left the military, became a critical care flight paramedic, and now I'm a second-year medical student. My Twitter handle is resuscitation, so feel free to tweet me, let me know what you think. Love to hear any feedback. I have no financial conflicts of interest. Now, this lecture is about CRM, or really rethinking CRM. And when I say CRM, I mean crew resource management. Sometimes in healthcare, we hear it referred to as crisis resource management. I actually specifically like the term crew resource management because I think CRM done well can actually avoid crisis situations. But what I really want to do here is go back to the roots of CRM, really analyze the initial science that came out of some very unfortunate incidents in the aviation world, and use that to sort of rethink and reform and build a new model using and applying CRM that I think we can use to optimize the care we provide inside and outside the hospital, and really take this concept of CRM to the next level. So, I know what some of you guys are thinking. You're just despondent. Oh my God, not another lecture on patient safety and all that airline stuff. Well, I kind of feel like a lot of the classes that I've seen taught about CRM and healthcare have been taught by people that, maybe they took an hour-long train-the-trainer class or whatever, and they're fairly vanilla, kind of Mickey Mouse. And although they have some good information, they're sort of lacking. Well, this is not that class. This is not Nurse Betty's patient safety class that incorporates some aspects of CRM. So kind of bear with me, hear me out, and let me know what you think. So going back to the beginning. So going back to the 1960s and 1970s in the commercial airline industry, there was a series of very unfortunate accidents that culminated with this tragedy. This is Tenerife in the Canary Islands back in March of 1977. Two airliners actually collided on a runway, killing 583 people, which is to date the most fatal event in aviation history. And this really kind of became a turning point in CRM. People began to realize that, wow, these incidents are much more complicated than we thought. It's really not just due to somebody's negligence or something stupid that somebody did or a lack of experience. Not at all. In fact, many people in these incidents were very experienced and not stupid people. But they were much more complex than that. And over time, in coordination between the commercial airline industry, NASA, and other organizations, we began to develop these programs, initially called cockpit resource management, and then crew resource management, and finally it sort of percolated through healthcare as crisis resource management. And we developed our own training programs in healthcare to address some of these human factors and to improve the safety in our care, which was good. Programs like Team Steps became very popular, initially started by the DoD, talking about things like debriefs and the 2-challenge rule, checkbacks, handoffs, structured communication tools like an S-bar report. All these things were great, and in fact there's been quite a bit of evidence supporting benefits in patient outcome when you use these individual tools, which is cool. But unfortunately, taken as a whole, these programs are sort of, they all kind of focus on their own thing. And the reason is because as people in healthcare approach this smorgasbord of very valuable data from the airline industry and from NASA, they just kind of took what was germane to them, their practice. So some courses focus on communication, others focus on teamwork or culture and leveling the structural hierarchy so that new people aren't afraid to speak up when they see something unsafe. Others focus a lot on health and well-being, and still others on situational awareness. Some programs are pretty good, and they actually incorporate numerous parts and numerous pieces of the puzzle. But taken as a whole, a lot of them, especially within the context or looking at it through the glass of acute care and resuscitation, are sort of fragmented, decontextualized, and somewhat incomplete. And I don't think they do it service. I think they're missing a little bit. So if you go back to the beginning, the inception of CRM, when some very smart social scientists and psychologists and engineers were looking at this stuff, it's actually really surprising. They don't tend to focus on any one of these individual parts. They focus on something kind of different. They use sort of a different language when they talk about this stuff. In 1979, Smith talked about the interaction of pilot workload with errors, vigilance, and decisions. And then in 1984, Clayton talked about factors affecting group process and aircrew performance. And still others talked about things like task management and decision-making under stress. So really, I think that leads us to a better definition of what CRM actually is, and the essence of that definition is alive today in how the FAA, the Federal Aviation Administration, refers to CRM, and that is the use of all available resources, equipment, information, and people to achieve safe and efficient flight operations. And I would take that definition and change it up a little bit and say safe and efficient resuscitation. And that's what I really want to do here, is take all of these pieces, all of these parts that have been other places in healthcare, and sort of bring them together into one unified doctrine of CRM that we can apply specifically to resuscitation of the acutely ill or injured patient in the emergency department or resuscitation bay, or even beyond the walls of the hospital. Now, before we get into what I think is a optimal model for us, I think it's worth touching on one important thing, and that is the title itself, Crew Resource Management, begs the question, well, what resources are we managing? Or really, better yet, what's the most important resource to manage? And I think that resource is the one right between our ears. It's the gray matter and the white matter inside our skull. It's our brain. It's our ability to process information. That's the linchpin. That is the crux, the bottleneck of getting things done, is how efficiently we can take information in and then process that information and generate ideas, make decisions, or perform skills. Now, I think the best discussion of this concept was really by Sweller in the 1980s, and he developed this idea of cognitive load, which is essentially that at any point in time, you or I or anybody has essentially a finite processing ability of your brain. And he initially talked about it within the context of learning new information, but it's been extrapolated and taken to applied to other areas, and I think it's definitely applicable to this area. And in particular in healthcare, one of the analogies we may have heard is this idea of bandwidth. So imagine this picture. This is essentially like your internet cable, and you can only upload or download so much information. It's sort of restricted, and that's your brain's. We'll pretend that's your brain's processing power. Well, unbeknownst to us, at some baseline level, your brain is processing all sorts of things on some baseline level, right? And then there's the stuff that we're not conscious of but can become conscious of if we really think about it, like the things we hear and the things we see, processing that information. And then, we're filled up, our brains are processing even more information. Things like questions that people are asking us, or things that we see, signs and symptoms that the patient displays, and taking that and then trying to come up with the best treatment strategy, and thinking about other things like drug dosages and whatnot. So you can see how this bandwidth can become essentially saturated. And that's what we're looking to avoid. That's what we're looking to manage. So I think, again, going back to the initial science that was that surrounded CRM, if you were to tease out some of the main lessons there in the process of how we manage this task load, I think you can sort of think about it in 3 key steps. 1 is prioritize, 2 is manage, and 3 is share. So something we're very used to, no big surprise, prioritizing, triaging what needs to be done, then using various tools and techniques to manage your own cognitive load. And finally, there's just so much stuff going on in these situations that you need to share part of that load. You need to tap into the collective bandwidth of all of your teammates and share information and tasks appropriately so that a lot of stuff can get done in a little bit of time. So first is prioritize. And I think when it comes to triaging this, the best mantra, the best way of thinking about this that I've heard is from a physician by the name of Dr. Joe Novak. He was a fighter pilot and is now an ED physician. And he talks about these priorities as resuscitate, differentiate, communicate. And this is a takeoff of the aviation mantra of first, aviate, second, navigate, and third, communicate. So I think this is really a really good way to look at it. So resuscitate. This is essentially maintaining vital function. So oxygenating, ventilating, and making sure your patient is well perfused. Doing things like stopping life-threatening external hemorrhage, and then really thinking about what's going on. So once you put that finger in the dike to prevent things from going south real quick, you begin to process and think about what's really going on here, what's the underlying pathophysiology, and how am I going to fix it? What's my treatment strategy? And finally, communicate. So putting all the other pieces of the puzzle together so that you can make this transport or resuscitation happen from point A to definitive care, wherever that may be. So next is manage. And the first step to managing is really about controlling yourself, controlling your physiology. I think it's really funny that stress is fundamentally a human element and certainly meets the definition of a human factor, but and is present in a lot of the emergency situations that we deal with, but very few programs actually talk about ways to manage this. And I think there are actually cognitive behavioral tools that we can teach people in order to mitigate some of that stress. Performance enhancing breathing, positive self-talk, different visualization exercises, and developing trigger words like focus are all part of those tools that we can actually teach people, train people to use so that they can manage their arousal and maintain clarity and focus in the face of absolute chaos. Also is applying different skills. So aside from controlling your physiology as sort of metacognitive process and introspective, you can use different skills to also manage that workload. So some of those skills include mental skills. These are skills of concentration and focus and attention, situational awareness, which I think has been largely poorly discussed. And most of the time when people talk about it, they say, hey, you just got to be aware. You got to keep your head on a swivel. You got to just watch the patient and be aware. And I think that's not really doing it justice. You can actually develop this as an active skill. And the best clinical example of this that I've heard is from the providers at Sydney Hems, and they train their flight paramedics and physicians, their retrievalists, in active processes. So when they're monitoring the patient, they actually teach them to look at the monitor, the ventilator, the patient. Monitor, ventilator, patient. Monitor, ventilator, patient. And this creates an active cycle, constantly watching what's going on around you. So you can detect subtle patterns or shifts or changes early on before the patient deteriorates and before the situation overloads your processing ability and saturates your bandwidth. The other thing is there's a whole host of our technical skills that we have to apply, right? Generally speaking, I think much to our detriment, we sort of exclude technical skills from human factors. But it's really hard to separate these things. I don't think we can just draw a line and say our technical skills don't influence or don't play a role in some of these human factors. I mean, you think about it. When you were really new at performing a procedure like intubation or starting a central line or whatever, you name it, placing a chest tube, you sort of fumbled through the procedure. Your first couple times probably weren't smooth. You really had to think about what's the next step, what piece of equipment do I need, and that absolutely saturates your bandwidth because you're entirely focused on it and you're entirely drawn in. And now think about it, things come much smoother. You just naturally flow through the steps. You don't think about them as 1, 2, 3, 4, 5. That processing load on your brain actually becomes lower when these skills become natural, when you can wield a laryngoscope or a scalpel so naturally it's like breathing. That frees up some of your bandwidth. So it's all part of it. Finally, using different tools at your disposal. There's a whole slew of cognitive offloading tools that you can use to sort of help manage your bandwidth. So the classic drug cards, dosage cards based on weight that are pre-calculated, so you don't have to go through and do the calculations on the spot. Using things like checklists. It's not the end-all, be-all. It doesn't solve all your problems, but a checklist that is designed well and implemented properly can be a very effective offloading tool. Also, how you set up your equipment is also important. If you're going to do a procedure and you're digging through all the pockets, or you get distracted because you missed a piece of equipment and it wasn't ready, that can throw you off, and that can add additional elements to your bandwidth that you don't want there. So by organizing your equipment appropriately, that also helps. Now, as much as we like to think we can do it all, unfortunately we can't, and we're going to have to tap into our collective bandwidth among the team. We're going to have to share some of this cognitive load. And the first step there, I think, is really leadership. It's about having someone who's designated to essentially making sure all the tasks get done, and delegating the right task to the right person at the right time. And this appears in very creative ways that I've seen applied in and outside of the hospital. A good example that I've seen is some helicopter EMS crews actually train very closely with their pilots, and on scene they'll use their pilots to actually read off the medical checklist, like a pre-RSI checklist. So the two medical providers are focused on what their individual tasks are, and you don't necessarily need someone who has lots of clinical training to just read off the lines of the checklist. I think that's perfectly appropriate and safe, and as long as it's trained appropriately, safe, and a good use of the collective bandwidth of your team. Also, communication. Now, I could dedicate really I could dedicate a whole lecture to any one of these individual pieces and parts. Communication in particular. I'm not going to spend a lot of time going over this because I think it's been explored and rigorously investigated by many people in the past. And this is one thing that I have to say I agree with essentially all of the available CRM programs out there, that clear, concise, direct, closed-loop communication is absolutely necessary to identify problems, discuss problems, divvy up tasks. Is absolutely necessary. I won't go too into depth on this one in this particular talk. And finally, your mental model. So part of really sharing that load is having part of that load shared essentially implicitly. This can be in the form of standard operating procedures. So you train a certain way to do certain procedures as a team. Everybody knows how that procedure goes down. It could be a complex or potentially invasive procedure, surgical procedure, RSI, or it could be a simple procedure like just loading the patient in and out of an ambulance or aircraft, or switching them over to the cot in the trauma bay. Whatever it is, if everybody knows how that procedure or process goes, you don't have to communicate. You can actually save time and move very fluidly and efficiently because you know what has to happen. Furthermore, if something's not done, it's easy to compensate for your team member, if you see they've forgotten something or something's not quite right, you can just go ahead and do it because you know what needs to be done. Also, it's not just standard operating procedures. You can develop a shared mental model on the fly. So let's say you're part of the helicopter EMS team. You're going out to retrieve a patient at a hospital, and you've been told that that patient is experiencing acute hypoxic respiratory failure. They're on BiPAP right now. You talk over your team. You look over the medical information that you have, and you say, hey, if this patient meets X, Y, and Z criteria, I really think we have to intubate them at the outside hospital. And so the whole team is now sort of talking it over, and you agree upon a plan, and now you know how that's going to go down. So you don't have to take the time and sacrifice the bandwidth to have that discussion at the bedside. So that's really an important part of this. So prioritize, manage, and load. Prioritize, manage, and share that cognitive load. I think that's a really important way to sort of conceptualize this whole idea, what we're really trying to do here. Reworking this, I think, is important for a number of reasons. But perhaps most important, I believe it needs to be reworked and readdressed in the setting of resuscitation because we need to see a paradigm shift in terms of how we utilize CRM. Traditionally, in the setting of healthcare, we talk about it in terms of preventing medical error and patient safety, right? So this is the model from James Reason that was presented back in 1990, 1991, something like that, where he talked about the holes in the Swiss cheese lining up, that this an error, something that goes wrong with the patient, is a result of multiple deficiencies, active failures, problems with the system, right? But I'm not just concerned about using CRM to sort of avoid these holes in the cheese from lining up. I'm concerned with making better cheese. I want to take this invaluable stuff that we've learned from various industries and we've adapted, and I want to make better cheese. In fact, I want to make the best cheese. I want to make world champion cheese. And really what I'm talking about here is performing better. It's not just about stopping errors or not screwing up. Yes, patient safety is absolutely important, but it's way more than that, I think, in these situations where we go out to resuscitate critically ill or injured patients. We need to do more than just not screw up. We need to be on our A game every single time. And I think part of the issue is we develop CRM from the airline industry, and the airline industry is essentially all about transporting people safely from point A to point B, and that's fine. There's no points for getting people there faster necessarily. There's no points for fancy or aggressive flying, and that to me is sort of like the hospital setting. Our patients or on the floor and whatnot are essentially fine. They're there for standard diagnostic procedures, or they're doing okay on the floor and they just need their meds. That's perfectly fine to say, hey, our priority is to not screw up, not hurt this person or make them worse. But those are not our patients. We don't need to use CRM like the airline pilots. We need to use CRM like these pilots, where we have essentially incentive to perform better, to fly better. These are our patients right here, the critically ill and injured patients that need our emergent intervention right away to save their lives. So that's why I think we really need to look at CRM in a different context to perform better. So prioritize, manage, and share. These things I think we can do that others may live. Thank you very much, and go ahead, check out this QR code, and it'll lead you to all the references to the lecture. Thank you.